Hi, I'm Jennifer Baughman with the Inpatient Palliative Care team, here to talk about the very special needs of our Comfort Care patients. Most units within the hospital will have a Comfort Care patient, which everybody knows gets the cart and stuff, but where else does that go from there? There's a lot of really special needs that these patients have beyond just making sure that that cart is filled. So we'll talk about medicating patients, the kind of physical care that they need, and certainly what resources are available to you as nursing staff to help these families, to help these patients to die peacefully. It does require a lot of support. It can be pretty intensive on a lot of different levels. But let's just talk about how best to take care of these patients. So there are a lot of ways to determine if somebody is having pain. And typically people at end of life, for whatever reason, will have pain. Certainly cancer patients will have pain. But also a lot of the ones that are comfort care within the hospital are elderly, and they hurt all the time anyhow, for whatever reason. These people aren't able to really move a lot on their own. When we see patients in the hospital that are comfort care, we typically expect them to die in the next few days. If it would be determined that it'll be longer than a few days, then these are the patients that'll be transferred out of the hospital to their home, nursing home, or something under hospice services. So these are very short-windowed patients that we're taking care of. They're not up moving around, they're not participating in therapies. And so if somebody is having pain normally, they will ring the bell, they'll tell you when you go in the room in your normal rounds. These people will not. But there's very easy ways to read the body without them having to verbally tell you that they're hurting or anxious. You'll notice the brow is furrowed. And these are all very basic nursing assessment tools. But prior to any fancy equipment, this is how people would be able to tell if somebody was hurting if they're not able to say. This could be they're not able to tell you because they're so far into the dying process, or they have dementia, or for whatever reason. Brow will be furrowed, they may be diaphoretic, pulse rate would be up, maybe blood pressure is up too. They'll have a change in their respiratory rate. It might be more shallow, certainly more rapid. While you're turning them, they may guard certain body parts that are affected. They'll moan. They may just be laying there still and moaning. These are all ways to say something is not right. They're hurting somewhere and it needs to be addressed. And certainly these patients should already have PRN medications available prior to the point that you're needing to call when you notice these type of things. When somebody is in physical distress, you'll see a lot of these same issues too. You'll be able to interpret that. And so you have the medications, it's there listed as needed for anxiety, for maybe chest congestion, for pain. Like very good nurses, you've made sure that your patients have these available. However, they're tools. You can have all the tools in the world, and if you don't utilize them when they need to be used, it causes a lot of distress for the patient and the family. And go back to what these people are doing. They are dying. They're dying, and if they're not medicated, they're dying in pain. They're dying anxious, they're dying congested, which really does not need to be. Because if you consider what the families are doing, they're holding vigil most times. They're in there, and this is what they're seeing, their loved one in pain, and they very rapidly learn to read that body also. It causes them distress to know that their family members are in distress. And as a side note, it's been expressed that the families often are ones that are calling, ringing, I think so-and-so needs some pain medicine, which is fine, but they should be able to feel comfortable knowing that their nurses are well skilled to read this body, that they are able to go home and rest, they're able to stay there and take a nap without feeling like they need to stand guard to make sure their loved one is medicated and hours of time are not going by. And then they feel very guilty. They feel guilty that somebody wasn't there all the time to make sure that somebody was medicated, when that shouldn't even have to be a consideration for their loved one at this point. They're in the hospital. What better place to make sure that they're medicated? And there's all sorts of ways to do that, to ease pain. If they're requiring a lot of doses, perhaps a PCA pump with a basal rate, and then they can push the button. There's Comfort Care medications that are available to be ordered. The hospitalists and the doctors are more familiar with those now. The morphine, the Ativan, the atropine under the tongue. So those things are available. If you have questions or think your patient's pain or symptoms are not addressed with the tools that you already have, tell your charge nurse, and things can be changed. But if they're there and they're not given, that really is not cool. So there are other non-pharmaceutical ways to manage patients' symptoms as well. Rubbing lotion, touch, talking softly to somebody, telling families it's okay to reminisce. We know that the hearing, they say, is the last sense to go. These people are too tired, too weak, too sick to participate in conversations, but it gives them an immense amount of comfort to know that their loved ones are close by at this very intimate time. If their symptoms are not well managed enough that the family can't bear to hear their loved one moaning in pain, they won't be there. So this is another consideration. This allows the family some peace to be able to wrap up some loose ends and spend some very beautiful time with their loved one while they're dying. The families need the support. Certainly pastoral care is available to help with that. Palliative care is available, social services. So it's not just the patient that needs the support, but it's the family as well. This patient isn't dying alone. They didn't live their life alone. And this helps the family to help this loved one to die. Medicating somebody, watching out for these symptoms, even turning them more frequently than the rule of thumb every 2 hours. If you try to hold still for just 30 minutes without moving, you can't. Nobody can. You'll shift, you're moving around. Rule of thumb is every 2 hours. These are people who aren't able to reposition themselves. If their arm has fallen asleep under their body, if their catheter tubing is grinding into their leg, if their knees hurt from touching, if their heels are aching because they've been laying in one position too long. These are all things to be very attentive of. And this is what I meant when I said that these patients are very labor intensive. You're constantly going in to see if they need medicated. You're documenting. You have to go back and reassess the effect of the medications or whatever non-pharmaceutical intervention you've done. And also coming back in, because these medications can be given very frequently, but also turning, repositioning. Oral care is very, very important. These people lots of times are on oxygen. Sometimes they're mouth breathing. And just think, if your mouth was that dry, it's really gross. You know, you get the buildup of the saliva in there. And so good oral care is certainly a large part of Comfort Care patients as well. These people still want to feel like they matter as a person. So combing their hair, shaving the men, lotion, I mean, all of these attention to detail things that they're not able to do really will help the family to feel this is a more peaceful, normal process also. So things that I wanted to throw out, myths that I've heard about medicating these people. One, they're not asking for pain medicine, so they're not having pain. We've already talked about that. They're not going to. Families shouldn't have to stand guard. We know now how to very thoroughly assess for nonverbal cues of pain, anxiety, and certainly with the lung sounds, you know if they are congested. That's pretty easy. So they're not, if they can't tell you that they're having pain, they're not going to be able to communicate relief, but you will notice a decrease in heart rate, decrease in blood pressure, the brow will not be as furrowed, they're not moaning. So all of these things that you did hear that indicated pain, you will not hear when their pain is relieved. I've heard people say, well, if I give them that medication, I will kill them off. I refuse, it's too high a dose. A lot of these people, especially cancer patients, have been used to living on high doses of pain medicine for quite some time. And so you take that away, or you're not giving it to them. That's kind of cruel, because they are hurting and they're not able to tell you. So they certainly do need to be medicated. They do need to have this to be addressed. It's very sad when families know that their loved one had needed large doses of pain medication because of whatever disease process they had at home, and they would take it routinely through the day, and suddenly it's just left at hit or miss of when they're going to do that. And then by missing these pain medication doses, we know that it will take several doses to catch up before this person is comfortable again. And so you're losing quite a chunk of time that could be quality time that their family can spend with them trying to keep medicated. I've seen nursing staff in tears on the following shift just because it breaks their heart to know that they had not been medicated and it was unnecessary. They see the distress that the families are in and they feel certainly distressed themselves. If it's there, you need to use it. You will not kill them off. And plus you need to look at the intent of these very high doses of medications. You're not looking to kill them. That's euthanasia. We don't currently have physician-assisted suicide laws here, so that is out of the window. The medications are titrated up. You're not started out immediately on a very high dose intending to end somebody's life or even hasten their death. That's not what we're about. We're about comfort. So they would start out with lower doses, titrate up till you get the maximum effect with the least amount of side effects. So we're not looking to suppress people's respiratory rate. We also know that as people end life, their respiratory rate does change. You see changed stoke respirations, you'll see periods of apnea. All of these things are very normal, coinciding events that really don't have a lot to do with the medication that you're giving. If you're uncomfortable with this or need further education one-on-one, please call me. I can show you articles. I can talk to you and help really ease your fears of helping somebody to die peacefully. A lot of people are very nervous about it, even if they've been in nursing for a very long time. And sometimes it's your first patient that you've had with Comfort Care, and you really don't know the resources available to you or to the patient. There's also the CISM team within the hospital. Sometimes we get patients that are very difficult to manage their symptoms. They're young, they have a sad life story, and you feel a lot of personal distress too. Those need to be addressed as nursing staff so you're better able to take care of patients in the future and you're not taking a lot of this stuff home, emotionally. And so Comfort Care patients aren't just managed physically, they're managed emotionally with the family support, socially, knowing if there may be complicated grieving issues, and where palliative care can help with that. And social services can help with that. They're also addressed spiritually too. So there's a lot of different types of pain, but really I wanted to address the physical pain because it does affect the emotional pain that the family can feel too. But just think of yourself, of your loved one. Sometimes it's very easy. I already have 5 patients. This person takes so much of my time. They're not ringing. I poke my head in, they look comfortable. It takes a lot more than that. And if there's issues with assignments, please talk to the charge nurse, talk to your manager to see how best to address these patients' very specific and complicated needs. So I hope this answered a lot of questions and give you a little bit of a more basis. Certainly, we're not hastening people's death. We all will have patients that die, but we want to make sure that they're as supported and as comfortable as what they can be at this point. If we can't change what is happening in their body, certainly we can make this time better for them and their family. Thank you.